Today's episode is brought to you by ALife Health. Managing IVF just got easier. Download the ALife app today for easy-to-use test result tracking, medication and appointment reminders, and a timeline to prepare you for the next steps. Your IVF journey all in one place. Now available on the Apple App Store.
You're listening to the Fertility Docs Uncensored podcast, featuring insight on all things fertility from some of the top-rated doctors around America. Whether you're struggling to conceive or just planning for your future family, we're here to guide you every step of the way.
Hi, everyone. We're back with another episode of Fertility Docs Uncensored. I'm one of your hosts, Dr. Abby Eblen from Nashville Fertility Center. And today I'm joined by my co-host and friend, Susan Hudson from Texas Fertility Center.
Hello.
And Dr. Carrie Bedient, the other person that's dancing in the corner from the Fertility Center of Las Vegas.
How you guys doing?
Hey, we're doing good. We were just talking about Susan and some mysterious picture frame. Susan, fill us in on the details of your picture frame.
So, I love gadgets. And I also, there are certain things in my armamentarium things of what are my gifts and what are not my gifts. So my gift is not creating photo albums. I take pictures. I take lots of pictures. They're all digital. When my family gets pictures taken, I always get the digital disc. But I have a plan in my life of when I'm going to sit down and make those little books that are of a trip or of a year or something like that. And I haven't yet hit that. But that is my goal after we finish one of our major projects that's coming up very soon. Okay. But that's still in the back burner. And one of my kids is getting their Eagle Scout. And so the option is I can print things and put things in a collage or frames or something else that really makes me have heart palpitations. And I was 10 years ago, the little picture frames that were digital picture frames were all the rage. And I was hey, I wonder if those are, and we had one and we never really used it because it wasn't very user-friendly.
I never used mine.
But apparently technology has hit the picture frames, and I am very excited that I literally can go from my phone with an app into my new picture frame that I got on Amazon that arrived at my front door, so I didn't have to go anywhere.
Now that's cool.
And I literally, through the app, can select the pictures, and they will miraculously show up on the picture frame. And then I think I can even organize them and stuff like that in the picture frame, and it will do a little slideshow. So I am very excited because it fits all of my qualifications.
Plus, it's so easy to do. That's really easy.
I know. And I'm so I have some pictures on my phone. My husband's been at most of the scouting events. And so I'm just going to snag his phone and be sending those little pictures, and I'll be all set for Tuesday without having a heart attack.
That is a great idea.
I'm impressed. I have a picture frame that I got for Mother's Day, I don't know, 5 years ago. It has never left its box, even though the concept is amazing. The frame itself is cute. It will go in my office. And have I actually executed? No,
nope.
No, I have not.
I think I had 2 of those picture frames over the years, and I've never used them.
You used to have to go from whatever you had your pictures on to a USB or something.
Yeah.
And the fact that it goes through Wi-Fi, you can even give these as gifts, and you can send pictures over. You get the identification link for the actual frame, and you can send them remotely. So say, you wanted your husband to have a picture frame. You never even have to see the picture frame. You just send him pictures of you.
That's great. If somebody does it for you, that's perfect. And then you get to choose the pictures that they get to look at. That's a great idea. Yeah, I like that.
This is not okay for me to know it, because what I'm going to do is I'm going to get this frame from my husband for Father's Day. And I'm going to upload it, and I'm going to control it. And then I'm going to give my children my camera, and they're going to take just insane pictures. And then I'm going to send pictures of doing ridiculous things. I'm going to have to keep it completely G-rated because he works in a children's hospital. But yeah, this is not
great. That's a great gift idea. Since you upload the pictures, that makes it easy.
Yeah.
Well, very good. So today we're going to do a question episode, and we're going to do it on male infertility because we haven't talked about you guys in a while. And so I know you have some burning questions that you want to hear about.
All right. So here's our first one. My husband was recently diagnosed with Klinefelter syndrome, and we want to have a baby that is genetically both of ours. He has high FSH and LH levels, testosterone around 25, small undescended testicles, and a semen analysis says 0. Is there any likelihood that we will be able to have children together? Everything seems negative about this condition.
I would say go see a reproductive urologist. That's the person that can answer the question. I know in some circumstances, and I don't know specifically about Klinefelters, but even men who have a really low amount of sperm have a really abnormal FSH level, which is concerning because that tells us that the testes is really kind of shutting down. Sometimes they can find pockets of sperm in certain places. They look through a microscope and literally, with IVF, the bar is really low. If you have 10 eggs, potentially if they can find 10 moving sperm, potentially you guys can get pregnant using his sperm. The problem with Klinefelters though is there's also a genetic component to it. And even if they find moving sperm, the concern is that there's probably a reasonable likelihood that the sperm may have too many chromosomes and therefore the baby, the embryo may not develop. So I think, we never want to say never in our field, but I think the chances are pretty low that it's going to be successful. But I think I would at least have the conversation with a reproductive urologist before you, decide definitively what you're going to do.
So, I would make additional plug for a male reproductive urologist with that extra training. And so There's a lot of urologists around who have a high interest in male reproduction and dealing with sperm and the hormones and all of that. But there is a distinct difference between those who have been fellowship trained by it because they have spent a lot of time doing the microtestes, doing that advanced level surgical technique that can potentially get you sperm. And so this is the time where finding the Uber specialist makes a difference. And they are not in every city. Like there is not one in Las Vegas. I routinely send
Really? I didn't know that. Wow.
I send to Mayo Clinic Scottsdale and I send to UCLA.
Wow.
And so that's something that is well worth looking at. Your REI should know who they trust and who they send to. And so that specialty is worth looking for.
Mm-hmm.
Completely agree. It is an uphill battle, but you want to make sure you have the right people on your team.
Yeah, without a doubt.
Okay, so this one is kind of on the other end of the spectrum. Hi, docs. I'm a 26-year-old female with PCOS and insulin resistance. My husband, 27, has been trying to conceive for 15 months now with no luck. Last year, about 4 months into our trying to conceive, I began taking metformin and been tracking ovulation. We thought this was our only issue, but as we were referred to a fertility specialist by my OB-GYN, my husband had 2 semen analyses performed. We discovered that he has a normal SLEEK count, 138 million, but low sperm motility. Since we now have 2 factors, would y'all recommend IUI as a first step for us, or do you believe we could be wasting our time with IUI and just jump to IVF?
So to make sure I've got the numbers right, it sounds like the count itself is fine. Motility is more borderline.
Motility is the issue. We don't know exactly what it is, but it's low.
Yeah. So what I have found in guys with counts like this is that when you prep the sperm for IUI, oftentimes you take a bigger cut than you anticipate. So for example, if let's say the motility is 10% out of a count of 138 million, you expect, we're going to have like 13 million. That's more than enough for IUI. Oftentimes what happens is when we prep the sperm,
they're less resilient.
And you just don't get quite as many sperm at the end of the day. And so you go to do the prep, you expect you're going to be fine. And then you realize, the prep, identified that more of them were not going to make the cut. And so you end up with a really low count. Now that won't harm you to do it. And most of the time we go ahead and do it anyway and say, have sex tonight, make sure that, we're stacking the deck as best we can. But it does end up being a far less effective use of both emotional and financial energy. And so there's no way to get around the prep. We have to do it. If we take a straight sperm sample, seminal fluid and all, and put it in your uterus, you're going to be exceedingly cranky at us. And it's not good for anybody because you will be very unhappy that we have done that. And so as a result, I would say my inclination tends to be screw it, go for IVF, because it ends up being a huge emotional burden that people don't really recognize, because the steps that you go through for an IUI, it's not that bad. Financially, it's not that bad compared to, what a full IVF cycle is. But if it's not going to end well, screw it. And it doesn't mean a guarantee that it's not going to end well. It's just statistically, it's less likely. So anything can happen, any miracle can happen, but there's a difference between possibility and probability. Anything is possible, it's not entirely probable, and so decide accordingly.
But here's what I would say. She's 26. She's young. It sounds like she has PCOS, although I don't know if she actually told us that, but she's on metformin. I assume she's ovulating now. So if anybody's going to get pregnant with a crappy sperm count, it's going to be a young female. The other thing, we don't know specifically, she said low motility, but if he had 200 million sperm, motility is a percentage. And so it's important to look at the absolute numbers. And that's where your fertility doctor will kind of help you decide if he's even in the ballpark where you could even consider IUI. And then the third thing I would say is there's a newer test out called a Sperm QT test, and not all clinics can do it, but it's a test that really essentially, it doesn't look at the basic stuff like a sperm count does. Sperm count looks at count, volume, motility, those sorts of things. This really looks at how well the sperm can get into the egg. And so I think you would be a great candidate to look at whether or not his sperm is really good. It's a new test, but we have one of our clinicians that did a test on somebody who had a really borderline low sperm count, but his Sperm QT test suggested that his sperm was excellent, meaning it had a really good chance of getting an egg, and they got pregnant on their second IUI. So that's sort of a different new layer. You may want to ask your fertility doctor if they have that test or can do that test, because that may give you a little bit more information about how good his sperm really is.
So another thing to think about is when Carrie was talking about, not knowing how the sperm was going to work in an IUI, you can give it one try. And one thing that I might recommend is a planned back-to-back IUI, because you can trigger for IUI. Normally you would do your IUI 2 days later. When I do back-to-back IUIs, essentially we do trigger and then we do IUI the next day and IUI the following day. Well, one thing that's nice is if you do that first IUI on the day after trigger, if you have amazing numbers, you may not even need to do the second one, because recent data supports that, there's really not a difference in that IUI timing. We like to have it as precisely as possible, but doing that IUI the day before, if you've got great sperm numbers, or if you need to do the two in a row to kind of add up the numbers to potentially get you good numbers for the egg to have a reasonable chance of actually getting fertilized is something to do. I would not do multiple IUIs on you. But I think potentially at least giving it a try. And like you said, like Abby said, age is definitely in your particular favor.
All right. What else?
Okay. Let's see. Hello, doctors. Thank you for the informative podcast. I've learned a lot since listening. My question is, in your experience, have you found that calcium ion channel blockers such as amlodipine are correlated with male factor infertility? My husband and I are trying to conceive for 1 year. I'm 31 with no significant past medical history. I have regular predictable cycles with evidence of ovulation, positive OPKs followed by basal body temperature rise following ovulation. Husband is 41 and only takes amlodipine for hypertension. No other prescriptions or supplements. Would love to hear your thoughts. Thank you.
So
I don't know.
Calcium channel blockers historically have blocked the ability for sperm to fertilize. I don't know that I've ever seen, in terms of experience, people where that has been the one and only factor and everything else is so pristine that we can exactly pin it on that. That said, and I didn't hear what her age, I heard his was 41. Did she mention her age?
I think it was lower.
Okay. I would say in something like that, really the best way to get around that is to do IVF with ICSI, because it's going to be a direct injection, or to have him stop the medication and switch to something else. The thing in terms of what to consider for how long do you need to be off the medication is going to depend on what the half-life is. Amlodipine tends to have a longer half-life. It's about, 2-3 days or so. So you figure by the time you've let 5 half-lives go through, that's about 15 days or so. And you add another 3 months onto that for the time it takes sperm to regenerate. So you're looking at like 4 months down the line. So depends on how much you want to try, what the overall factors are. If you've got other fertility factors, you may want to put less emphasis on that. If that is the one and only thing and everything else is absolutely pristine, you may want to consider going off the med. But I would say talk about that with your doc, because that's going to be a multifactorial decision.
I would also mention that the hypertension itself can potentially increase your risk of kind of modifications in sperm that may not be helpful. As you know, if you believe in DNA fragmentation, I definitely see more DNA fragmentation in guys who have high blood pressure. It would make sense when Abby was talking about Sperm QT, we're looking at modifications in the genetics of the sperm that could potentially have an issue. So I would, in addition to potentially changing medicines, I would encourage, working on lifestyle modifications to help him get as healthy as possible, whether that's diet, exercise, losing weight, helping decrease those risk factors. If you're smoking, for the hypertension at 41, kind of get both of you as healthy as possible. IVF is not just IVF, fertility is a team sport. So we need everybody kind of putting their best foot forward.
Yeah, and I would just add, over the years, I cannot think of a time when I know that somebody's been on a calcium channel blocker and it's had a significant impact on sperm. I think kind of like what you're saying, Susan, it's more lifestyle changes, that sort of thing that may be beneficial. But I mean, it's an older drug and maybe that's the only drug he responds to, but I bet you there's other drugs that are newer drugs that he could respond to. And, maybe it'd be worth making that change, but it would take about 3 months probably to really see a benefit from any changes like that. So it's worth making the change just to see. But, depending on what your age is, if you're close to 40, I would think about moving on to more aggressive treatment sooner rather than later.
It's interesting that he's on that medicine. Usually you don't see that as
it's a real old medicine.
Therapy, like the first medication to be put on, there's so many others.
I see it a fair amount.
I can't remember the last time I've seen amlodipine.
Oh, I get
a lot of lisinopril lately, but and Norvasc.
Yeah. Interesting. All right. Our next one, my husband, 36, and I, 30, have been trying to conceive for 2 years now. We just had our first appointment with our fertility center, and ICSI has been recommended. We are going through male factor infertility, where 0% are motile, 98% head defects, 63% mid-piece defects, 90% tail defects, concentration 1.86 million per mil, and sperm number 4.76 million. It has been recommended by our specialist that he take a male fertility vitamin. How much will that help regards to motility and increased count? Are we willing to do anything at this point to better our chances, but would really like an explanation to understand why?
That's tough. Zero motility is it's not a deal breaker, but it makes everything harder. I mean, I think a lot of this goes back to lifestyle changes. Is there anything that you can do that will improve things? I don't think the vitamin supplements are going to hurt at all. I think
they are not miracle pills, though. They are not miracle pills. Really the question is, are the vitamins worth it? Are the vitamins worth it? Yes. Okay. Because if you can make some impact into that sperm function, go for it. But they're not going to go from this to something you don't need IVF for.
Mm-hmm. And the other thing to consider is that right now you're looking to go from nothing to anything, something, even the tiniest little bit, because right now your embryologist, if they do IVF, they're going to be struggling to figure out which one of those little suckers is alive, because that's where motility is really valuable when you're doing IVF. It gives a very clear definition as to which sperm are alive and which sperm have the best function, because they're moving forward in a straight line rather than doing donuts in the parking lot or just being a complete couch potato and sitting there twitching or not doing anything at all. And so right now, if you can get any benefit, that benefit is going to go towards IVF. Now, again, we're all for miracles. We will take them at any stretch of the imagination whenever we can get them. But I am not super hopeful that this is going to happen with lesser treatment.
Well, my question is, why does he have zero motility? He's 36 years old. Is he on some sort of medicine? I've seen some people sort of before testosterone completely knocks out the sperm count, they become immotile. So think testosterone. Is he in heat a lot, out in the environment, in a hot tub? Is he biking a bunch? Biking can create friction in the testes. One time I even had a patient who was an embalmer, and he was around a lot of formaldehyde, and he had a lot of sperm, and they were all dead. And, I don't know for a fact that it was from that, but there was a Chinese study that I looked up where they sort of said formaldehyde can kill your sperm. So
dry cleaners too. They're around a lot of nasty chemicals. So you can see some dry cleaner impact.
And I've had two guys over the years, if you happen to listen, if someone listens to his heart and his heart happens to be on the right side instead of the left side, that's called Cartaginer syndrome. And so that also is associated with no motile sperm either. And that's unfortunately is not a reversible thing. But in the case of my patients, both of them had a lot of viable sperm. So just randomly selecting a sperm didn't respond to anything that we did in the lab to show which ones were motile, but just randomly selecting sperm with 80% viability. Both of those patients ended up getting pregnant with IVF. But I would have him see somebody to try and see if they can figure out why his sperm are not motile. And maybe they can't figure it out, but it's worth a try because it may save you from having to do IVF.
I have sometimes used like FSH and HCG in these guys to help get things moving, and the results are not amazing. I could not tell you what the mechanism was to save my life of why that works, but I have occasionally tried that and had some improvement. Now, I don't know if it was just the random luck of the first one sucked and the second one after meds were better, or if it was actually a concerted help. But in cases like this, and
I think it would make a difference too if he's making a bunch of sperm and they're not motile versus he's not making many sperm at all and they're not motile. That's sort of a different. I think it'd be worth seeing a reproductive urologist doing hormone levels in him just to see if you can get at the reason why doesn't have any motile sperm before you jump to do IVF immediately. Anyway,
you may still need IVF, but if you're really wanting answers, those answers may be available with a little more digging.
Yeah.
All right. Hello. Thank you for all you do. Your podcast has been a godsend over the last 2 years. I'm 33 years old with no significant medical history. I've been seeing a repro endo about a year with 2 failed IUIs. My husband and I have gotten pregnant naturally twice in 2 years, both ending in miscarriage at 7 weeks. All fertility testing was normal for me, including an AMH of 6.7. Husband's sperm count was low at 9 million with 4% morphology. He saw a male fertility specialist and started taking Clomid due to low testosterone, vitamin C, and a fertile aid supplement. He is otherwise a healthy 33-year-old male with no medical history. Where do we go from here? Keep trying naturally or pursue IVF with PGT testing. I cannot handle more losses.
The key to the kingdom is that last statement.
I was just about to say that. I can't handle any more losses. That's the keys to the kingdom right there. Yeah.
Like you have just identified your priority. And what I tell ad nauseum to my patients is you tell me what your priority is and I'll tell you how I think the best way to get there is. Because if your priority is I can't handle more losses, you start to go aggressive, you do IVF with PGT, and you start to eliminate as many factors as you can. If you say your priority is, I don't want any intervention, then you keep trying naturally, knowing that you're setting yourself up for either waiting or more losses, potentially. And so that identification of the priority, you are amazing. You have told us what you want. And so that tells us need. Yeah. That's a huge distinction. You have told us what you need. And so we will tell you, okay, this is probably how we want to get there the fastest. Please make sure you've got mental health backup. So therapist, counselor, spiritual leader, whomever is your jam, get that backup because your husband and your best friends and your mom and family and all of those people are amazing, but you deserve someone who does this all the time. And so get that backup because going through IVF is also going to be triggering. Going through that transfer is going to be triggering. And so have a little extra help.
Agree.
All
right. One more, guys?
Let's do it.
All right. Hi. I am wondering why sperm count for IUI is approximately 5 million or more for the IUI to be successful. We are currently going through IUI and my husband's sperm has been 3.8, 4.2, and 3. We are told this is not enough for IUI and have been recommended for IVF. But what is crazy to me is that 3 to 4 million isn't enough for IUI. Wondering your opinions on why a patient needs millions and millions for IUI, but you only need one sperm to get pregnant. What happens to all the sperm once it's up there? How could you need so much? LOL.
Well, we can ask God first, but what we think is going on is that half of the sperm, some of the sperm get caught up in the mucus, half the sperm go one way, half the sperm go the other way, only one of them gets to the egg. And then to penetrate the egg, you have to have a whole bunch of sperm to bore a little bitty hole in that egg, and they all produce enzymes, but it's sort of their collective group there that bores the hole in the egg to get the sperm in. And so I don't know that anybody knows with absolute certainty why you need a certain number, but I think we'll all say, you can never say never in this field. Have I ever had anybody with a 4.2 million get pregnant? Sure, I have. Have I had somebody less than that? I think 1.7 or maybe even less than a million. I've had somebody that's gotten pregnant with an IUI. But, like Carrie said earlier, we're just looking at the likelihood and we don't have a crystal ball. So as a general rule, we give our patients a general guideline. Nothing is ever black or white medicine. It's not going to hurt you to continue to try with his numbers that low. But, we want you to have a baby at the end of this. We don't want you to just keep coming back month after month after month after month. So our job is to help you figure out what's going to be the most successful for you. And I think what your doctor's trying to say in a roundabout way is, you can do these IUIs, but you're going to spend money and time and your chances are going to be exceedingly low, not zero. And your best bet is to do something like IVF because that will get you pregnant the quickest, basically.
When you look at the 5 million number that we are going for, everything's on a continuum. And so they've done studies that have shown, okay, if you have 20 million, 10 million, 5 million, 2 million, whatever, these are what your success rates are. And so 5 million is the somewhat arbitrary number that people have set, saying, okay, if you have less than that, it's really not worth it. And so it is a somewhat arbitrary number. And all of us have had people get pregnant on ridiculously low counts that we're looking at going, this is never going to work. And then lo and behold, the patient has the audacity to get pregnant.
Which we are very happy for.
Yes, we are. We're thrilled when that happens.
Yes, we are. Even though it makes us look like we're morons. So that's part of the reason why. Now, please keep in mind, human reproduction is mortifyingly inefficient. So when you think about a normal ejaculate has the upwards of 50 million sperm in it. So we're not talking about fertility patients. We're just talking about average, Tom and Betty who are trying on a Saturday night. And an average ejaculate has like 30, 40, 50 million sperm in it. And if she's ovulating, that's still only a 20% chance of getting pregnant. Now, if you told me...
And that's best case scenario.
And that's the best case scenario. And so if you told me that you're going to have 50 million workers go to do a job and there's a 20% chance that they're going to get it done, I would say fire that company and move on. You can't really do that in reproduction, but just remember it's a horribly inefficient process because the body really wants to make sure that everything is right. Pregnancy is an inherent risk to the woman carrying the baby. And so if everything's not right, it is far better for that pregnancy to not go forward. And a lot of times that happens before a woman even knows that she's pregnant at all. Like she doesn't even get to the point of a missed period. The egg and the sperm may get together. They may have their little party, but it's really just a one night stand. And they're like, nope, this is not going to work out. Done. So that happens way more. I mean, upwards of 50% of pregnancies never get clinically recognized because they're like, yeah, I don't like the way you do your hair. You do not get a second date. And off they go. And so that is a long-winded answer to say, yeah, it's inefficient. 50 million is just not enough, much less 5 or 3 or 2 million. And I hear your pain and I'm really sorry, but no.
So Carrie, you had like 3 analogies in that one explanation. Susan and I were over here, we're cracking up. You must have been the kid in the back of your biology class or math class that made the other kid laugh and got the other kid in trouble. Were you the one that did that?
Oh, no. I was always in the front row. I was a 95% and above kind of student. Okay. I was like, all these crazy thoughts were going through my head, but I didn't learn until I was deep into my 20s, probably early 30s, that
if you shared everything that was going on in your head, people were going to laugh.
Pretty much. But by that point, I was established enough in my career that I was as a human being that I was like, screw everybody else. Like and I just started talking, and turns out it was a good life decision because I'm much happier.
We're glad you started talking, Carrie.
Yes, you make us laugh, Carrie. We love that.
All right. So I think that's about it for today.
Sounds good. Okay. To our audience, thank you for listening. Be sure to tune in next week for more. Keep your ears tuned and peeled and eyes tuned. That's the mixed metaphors in there. Anyway.
Your eyes focused.
October 28th. It's the conference. Come see us. Come play with us. It'll be grand. New Braunfels, Texas, between San Antonio and Austin. And it will be grand. Be sure to subscribe. Leave us a review on iTunes and Apple Podcasts. I guess iTunes doesn't exist. And we're on Instagram, we're on Facebook and YouTube, and I'm really excited. And so clearly I'm not saying everything clearly, but hop on by, send us a like, send us hello.
And this is Carrie without alcohol too. So when you see her at the conference, she'll probably have some alcohol somewhere along the line. So she'll be even funnier probably. So.
Oh, I do get very unsettled. I get completely unfiltered. And these are my filtered thoughts coming out. I will be unfiltered. And yeah.
All right. So back to, you can also visit us on fertilitydocsuncensored.com to submit specific questions. All questions will be answered on the podcast for the Ask the Doc segments, just like we did just a minute ago. We'd love to hear episode ideas. Can't wait to hear from you. We'll see you soon.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon. Bye. Today's episode was brought to you by ALife Health. Whether you're currently going through IVF or looking to create a digital record, the ALife app can help you stay organized, informed, and empowered throughout the entire IVF journey. Download the ALife app today, now available on the Apple App Store.